Hey everyone, welcome back. Grab your markers and your notebooks because today we are doing a high-yield, whiteboard-style masterclass on a truly massive topic, multiple sclerosis. Now, whether you're prepping for NEET PG, INI-CET, your board exams, or you're just gearing up for clinical practice, we are going to draw out the pathways, highlight the absolute must-know mechanisms, and completely demystify this disease, from the cellular level all the way to modern management. Right off the bat, we have to start with the core question, right? What exactly is multiple sclerosis, and why does it matter so much in the clinic? To answer this, we're going to trace the pathophysiological pathways step by step together. We're going to see exactly how an immune system, basically gone rogue, leads to these really profound neurological deficits. And trust me, by understanding the underlying mechanism, the clinical presentation and the treatments are going to make perfect logical sense.
Okay, let's dive into this. Here is our syllabus for today's explainer. What is MS, pathophysiology and demyelination, high-yield clinical presentations, diagnosis and the McDonald criteria, disease course, and we'll wrap up with management and escalation logic.
Starting right off with Section 1. What is multiple sclerosis?
By definition, MS is an autoimmune disease, but here is the key. It is restricted entirely to the central nervous system. It's characterized by chronic inflammation, focal demyelination, gliosis, which by the way just means scarring or sclerosis, and crucially, neuronal loss. Basically, this is an immune-mediated attack on the CNS, and it affects over 1 million people in the United States alone. It's a disease that typically strikes young adults, and it can cause profound, lifelong disability.
Let's move into Section 2, pathophysiology and the demyelination process.
I want you to imagine we're drawing this out on a whiteboard right now. Picture the blood-brain barrier. Now take a yellow marker and trace the lymphocytes, so we're talking T cells, B cells, and macrophages, as they disrupt and literally push their way across that barrier. Once they get inside the CNS parenchyma, they target the myelin sheath. And as they destroy this fatty insulation around the axons, the action potentials start to slow down, or they just fail completely. Finally, astrocytes proliferate to try and heal the damaged area, forming a hard scar, or gliosis, while the naked axon itself is left incredibly vulnerable to degeneration.
For your exams, you absolutely must know these pathophysiologic hallmarks. First, note the perivenular cuffing. This is exactly where inflammatory cells cluster around the small veins. You'll also see ectopic lymphoid follicles out in the meninges, and these basically act like localized immune factories. On a pathology slide, you might spot shadow plaques. These are areas where oligodendrocyte precursors actually tried to remyelinate the axon but failed, leaving this really thin, shadowy coat of myelin. But here is the most important concept to highlight today, the distal retrograde dying back axonopathy. It's this cumulative structural loss of the axon itself that truly drives the irreversible physical disability we see in these patients.
All right, Section 3, high-yield clinical presentations.
So how does a patient actually present? Well, the most frequent initial symptoms are basically a three-way tie. Sensory loss comes in at 37%, optic neuritis at 36%, and weakness at 35%. Now, I want you to mechanistically anchor these symptoms. If our rogue immune cells attack the myelin of the optic nerve, you get optic neuritis, right? Unilateral eye pain and vision loss. If they attack the sensory tracts down in the spinal cord, you get numbness or paresthesias. And if they hit the corticospinal tract, you get classic upper motor neuron weakness. It all comes back to anatomy. Structure dictates function, and where the demyelination happens dictates the symptom.
Okay, here's your checklist of classic high-yield board prep buzzwords that every single student needs to highlight and master. First up, Lamite's sign. The patient flexes their neck forward and bam! They feel a sudden electric shock run straight down their spine. It's a very visceral, classic sign of cervical cord demyelination. Then there's internuclear ophthalmoplegia, or INO, which causes double vision because of a lesion in the MLF. What about exercise-induced weakness? Well, when a patient's core body temperature rises, their already compromised axons just fail to conduct properly. Add in hyperreflexia, spasticity, and bladder dysfunction, and you have the complete classic clinical picture of MS.
To actually measure these clinical deficits, we use something called the Expanded Disability Status Scale, or EDSS. It's a super crucial tool used to score impairment and track the progression of the disease over time. The main threshold you need to remember here is around 3.5 to 4.0. Basically, if a patient is scoring under 3.5, they're generally fully ambulatory. But the second they cross that 4.0 threshold, we're unfortunately looking at progressive gait impairment and pretty significant disability.
Let's keep it moving to Section 4, diagnosis and the McDonald criteria.
Now, what's really interesting about this slide is the logic behind the diagnosis. The golden rule of MS is proving that the lesions are separated in time and space. And the 2017 McDonald criteria breaks this down beautifully. For dissemination in space, or DIS, you need at least one T2 lesion in 2 out of 4 classic CNS regions: periventricular, juxtacortical, infratentorial, or the spinal cord. Now, for dissemination in time, or DIT, here's the kicker. You don't even have to wait for a second clinical attack anymore. A single MRI showing both an old non-enhancing lesion and a new active gadolinium-enhancing lesion at the exact same time proves that this inflammatory process is ongoing.
So when you're actually looking at that MRI, keep an eye out for these classic findings. Dawson's fingers are an iconic radiographic hallmark. Remember that perivenular cuffing we talked about earlier on the whiteboard? Well, those veins run perpendicular to the lateral ventricles. So the demyelinating plaques trace right along these veins, creating these weird finger-like projections. You can also look for the central vein sign on T2 star sequences. And if you tap the spinal fluid, finding oligoclonal bands, or OCBs, acts as a major diagnostic pillar. It literally shows us that B cells are actively producing antibodies inside the CNS.
But beware the mimics, guys. This is an incredibly critical distinction for your exams. MS versus neuromyelitis optica, or NMO. In MS, spinal cord lesions are usually relatively short. But in NMO, you are going to see longitudinally extensive transverse myelitis, meaning massive lesions spanning 3 or more contiguous vertebral segments. Furthermore, NMO is driven by very specific antibodies against aquaporin 4 water channels. And unlike MS, NMO rarely has a slow progressive phase. Instead, the profound disability comes straight from severe, devastating acute attacks.
Okay, Section 5, Disease Course and Variants. Let's look at the timeline.
Let's draw a timeline right across the board. It actually starts years before the very first symptom, with radiologically isolated syndrome. These are just incidental MRI findings in a totally asymptomatic patient. Year 0 is that first actual clinical attack, known as clinically isolated syndrome. For the next decade or so, most patients enter the relapsing remitting phase, where they experience acute attacks followed by recovery. But eventually, usually around year 15 or so, the disease shifts into secondary progressive MS. This is where the relapses stop, but the patient experiences a slow, continuous decline in neurological function.
And this brilliantly illustrates a total revolution in how we understand MS today. We used to think patients only got worse during those acute relapses, but now we know all about silent progression, or progression independent of relapse activity, abbreviated as PIRA. Insidious, smoldering neurodegeneration and axonal loss are happening quietly in the background, even super early on, without any overt clinical attacks at all. And honestly, this completely changes how aggressive we need to be with early treatment.
Now, before we get into those treatments, I want to quickly note a few extreme high-yield variants. Marburg's variant is a fulminant, incredibly aggressive form that can progress to death within just a year or two. Tumefactive MS presents as a massive, swollen lesion that looks exactly like a brain tumor on an MRI. And then there's Ballow's concentric sclerosis, which paints a very vivid, kind of terrifying picture in the white matter. You see alternating concentric rings of demyelination and remyelination, making it look like a literal target on the scan.
Finally, Section 6, Management and the Logic Behind Drug Escalation.
Let's wipe the whiteboard clean and build our overall strategy. The absolute crucial point here is differentiating our therapeutic goals. If a patient is having an acute attack right this second, we hit the inflammation hard with high-dose glucocorticoids, or we use plasma exchange if they don't respond. But for long-term management, and this is because of that silent progression we just talked about, the modern logic is to start highly effective disease-modifying therapies, or DMTs, early. We're talking drugs like ocrelizumab, which is an anti-CD20 monoclonal antibody that wipes out B cells, or cladribine, which targets lymphocytes. The whole goal is to halt that insidious axonal loss before it even happens. And of course, never forget the supportive stuff: symptomatic care, physical therapy, and correcting any vitamin D deficiency.
So we have these incredibly powerful tools to stop the immune system from attacking, but we are left with a massive frontier ahead of us. If our current therapies can successfully halt the inflammation, how will we unlock the secret to promoting remyelination, healing those shadow plaques, and fully repairing the central nervous system? That is the next great medical challenge, and perhaps one that you'll help solve in your future practice. Keep studying hard, keep asking those big questions, and I'll catch you in the next explainer.